So I'd like to welcome everybody to our webinar this morning, the benefit of CT imaging in dental cases. The title has changed a little bit. Dr. Henry changed the title, but it mostly is about equine dentistry and how CT imaging can help you. It's sponsored by Asto CT, like our other webinars were. We have a panel of experts that will help with answering the questions. First, let me introduce myself. I'm Sabrina Browns. I'm a professor in large animal surgery and equine sports medicine at the University of Wisconsin. And I have a lot of experience working with the Equine CT Center, CT scanner. We use it a lot in our hospital, mostly daily, except the weekends. And I also help the R&D department of the company to help with development of new things. We also have David Ergen this morning. He's the CEO of Asto CT. He has a background in physics, and he can help with all the technical questions about the Equine machine itself. And of course, we have our speaker of today, Dr. Travis Henry, and a little bit more background on him. He is a graduate from Michigan State and completed a residency at UC Davis. He's unique in the sense that he has obtained a board certification in small animal as well as equine dentistry, and there's not a lot of dentists that can say that. He has owned Midwest Veterinary Dental Services for over 15 years and recently became an adjunct faculty member here at the University of Wisconsin. He's well known, national and international, for his expertise in dentistry. And before I hand over the microphone, or actually I should say the screen, to Dr. Travis Henry, I would like to let you know that we will answer questions during the presentation as well as at the end. And I would like you to ask the questions through the Q&A function that's at the bottom of your screen. So some of the questions we'll answer directly, but we'll try to save as much as possible for during and after the presentation. There will be certain spots during the presentation that I can answer Dr. Henry some questions that you have. And so without any further delay, I'd like to hand the screen over to Dr. Travis Henry.
Thank you, Sabrina, and thanks to everybody that's coming into this meeting with us. And I have to say it's a new thing for me to be giving presentations over a live internet chat like this. But the biggest thing I miss about this is not being able to see all of your faces and know who actually is here. So if I know some of you or we have met before, hello again, and to the new ones, it's nice to meet you. So I am first going to start out by saying that I'm not a radiologist. I'm a veterinary dentist. So a lot of what we're going to do today is going to be based on the clinical cases that we have seen at the vet school or have come to me over the last year or year and a half. And so I've tried to make this very clinical, but there are some points that we need to start with. So if we go to our agenda, we're going to run over just a few things that I think we need to get a groundwork on. How does CT really help you in some of the different things that you can do with CT over, say, plain radiography. And that comes into the techniques that we can use, the filters, the multiplanar reconstructions, and the three-dimensional reconstructions that we can do. Then we're going to dive into some clinical cases that are related to dental disease and also sinus and nasal passages. And then I know that there's been some other presentations made on different areas of the head because I basically only practice on the ears forward of the horse. The rest of the body is just the life support for my area of the head. But we will discuss briefly fractures. We'll dive into some temporomandibular joint things, dentigerous cysts, and then the all dreaded oral nasal or oral sinal fistulas. And then we'll have a brief time for summary conclusion. And if we have a little bit extra time, some more questions at the end. But in each of these different areas, we will stop for if you have some questions. So techniques. When we first look at what CT can do, there's a wealth of information that's gained when we perform a CT study. And the nice thing about where CT has gone is we can actually ask it to give us either a bone window or a soft tissue window. And this is where David could add in at some point if there's questions in this area. But for me as a dentist and what we're going to look at today, a lot of it is going to be in the bone window where it really highlights the bone and the high detail of that. But when we look at the soft tissue window, and I've put two images side by side in the same region of the head or close to demonstrate what the bone window does. But when we go to the soft tissue window and we're looking at this very large sinus cyst in a young foal here, you can see that we can actually start to look at different levels of density within the soft tissue. We can see muscle planes of the tongue, the muscles of mastication, and there is definitely a nice use for this when we start to look at things that are involving the soft tissue. And here's just another one where we can actually bring out even more of the soft tissues, where we've got a cyst laying in the ventroconchal bulla, and we'll talk about those a little bit later. But you can see the well-defined region that this can give us. But on the bone window, this kind of brings out more of the sinus architecture, where with this, we wanted to look specifically at the soft tissues. So just remember that you can look at different things based on how you set up the computer to show you these images. So a lot of what I like to use in CT when I'm using a viewer is the multiplanar reconstructions, because we're doing a lot of these, of course, standing, and that's a wonderful thing, because first of all, we can scan a horse sometimes within 15 minutes. I can have it down in the standing surgery area shortly after that, performing either an oral exam or taking some detailed plain film radiographs of areas that we need for surgical planning, along with what we captured in the CT, and be starting a surgery within 45 minutes of that horse becoming sedated. So that's really cool that we've come to that point in practice where we can actually perform the CT and be doing surgery right on the same sedation episode. But when you put the horse in the CT scanner standing, sometimes they're a little crooked, or they're well sedated, they're not moving, but they're not exactly positioned very straight. And that can create problems when you're looking at just the native images. And we're going to talk about multiplanar reconstructions because we can compensate for that and straighten them out. And the first thing we have to understand are what are the three-dimensional images that we typically see. The first one would be the transverse image. And this is as if we've cut the horse's head in a cross-sectional view. So in this, we can see the sinus compartments here, the nasal passages. Here's your bullas of the nose and the rostromaxillary sinus. And in this horse, we can see that there is bone lifting off of this tooth. We've got a sinusitis going on as well, but this is going to be a problem with this tooth. But we're looking at this in a transverse. The next one then is the sagittal view, where we're slicing the horse's head kind of longitudinally. And this we can use to look at all the teeth together. We can look for diastomata between teeth. We can look for horizontal and vertical bone loss when we start to talk about periodontal disease. But this is a view that can be made in the multiplanar reconstructs to give us a sagittal view. And the next one then is the dorsal, or some people call it the coronal, but in veterinary medicine, it's quite widely called the dorsal. This is where we can actually look straight down on all of the endodontic chambers of the teeth. So when these images are made with the computer based on the volume of information that you've gleaned with the CT unit. And when we go then to what does that screen look like, and you can see in this actual case that this horse wasn't exactly straight in the CT. You can see there's some changes in where we can see the eye here and we can't see it here. The teeth, we can kind of see the clinical crown of one and the other here. And then the horse you can see in this dorsal view was actually not straight. So just a little bit on this is this purple line is your transverse view. This blue line is going to be how you're slicing for your dorsal. And the yellow line is going to be what you're slicing for your sagittal. So I know that might be a little bit confusing, but we're going to move on here and show you how this all functions. So the next one then is where I've corrected for all of this. And you can see now that we are cutting more for our sagittal right through the dental quadrants, but we could also adjust this so that we can see all of the teeth at once here. We've lined this up to be perpendicular so that the dorsal view is right in the same parallel plane as the palate, and then we're perpendicular to the palate so that we can look at the individual teeth nicely without getting part of one tooth and part of another tooth in the same transverse slice. So this is just a little video of that happening. And you can see as my mouse moves around, so this was a video that I made as I corrected that and came up with the image that we saw before. So you're going to see us be able to adjust So we're going to grab the rotation device here, and I'm going to spin the horse so that I can get it lined up. And then as you can see, as we move the axis over the dorsal, how our transverse planes and our sagittal planes started to straighten out. And now I'm going to tell the dorsal line on the MPR to flatten out. Now you can see all of the teeth together, but as I turn that back to where it was, you can see how we lose that. But there's a good reason sometimes to reposition this line so that we're actually following a tooth. So say, let's go look at the number 11 tooth that angles distally, and we're gonna a lot of times want to be right on that tooth. So here we're going to look at the 9, so we can see those coming into view nicely. And then as we go back a little bit farther, and we want to look at the 11s, because you can see here we're seeing part of the 10 and part of the 11. So I can angle that back. And now I'll be able to scroll back through the slices a bit and get both of the 11s individually there so that I can compare right from left. And this is if you double tap on that particular image, it blows it up into full screen. So I just wanted you to see how useful and how powerful CT can really be for looking at things. It's not just scrolling through a bunch of transverse slices that came out of the image, out of the machine to look at. And especially when we're talking about teeth that have 5 pulp horns in each one, a common chamber, and the maxillary teeth, 3 root canals, and 2 infundibula. It's just so much information in each tooth that we need to examine, that with being able to put this into the multiplanar reconstructs and actually angle this so that we can see up through a tooth on, say, the dorsal plane. And here I'm correcting for even the shape of the mandibles by moving that yellow line so that I can see all of the mandibular teeth when I'm actually evaluating for periodontal disease. So it's a really powerful feature that we can use in CT. The bottom line is that when the native image of this horse came in from the unit and you would just scroll through the native dicoms, you could see that this is part of the occlusal surface of one tooth, and then we're picking up a little bit of the apex of the other. And that was just how the horse's head was in the CT unit. Because if we go back to this, if the head is angling down a bit and the CT is slicing them in this region, what you're going to do is clip off part of one tooth and part of the next. So when we go to this image and look at what we've done in the MPR, you can see that now we're able to look at each tooth. And the nice thing about this is that we can compare right and left. So hopefully there's a normal tooth in this horse on one side and an abnormal on the other. And when we compare them, you can easily see that here's our problem with the sinusitis involved there. So hopefully that kind of helps people understand how powerful CT can be and all the different planes that we can put and glean from this to look at individual structures. The other thing that's really nice is 3-dimensional reconstructions. The CT unit then can take all of this volume of information and give us a 3D rendering of the patient. And you can ask it to look at soft tissue. You can window level yourself till you put the skin back on, or you can go all the way out till you can see the halter that was on the horse. But the important thing for me in this is skull fractures and different things that can happen to the external face, because it's really neat to be able to see the extent of it. And this was a MRSA case, so methyl-resistant staph case, that came to us with a chronic sinusitis, and it had a trephination made right in this region. And this frontal suture got infected with this organism, and we started to see problems and changes, and we CT'd this horse multiple times to follow it. And the prediction was that it was going to follow the suture line. And so we've got several CTs showing where it was just to midline, and then it progressed on across. And actually you can see where it went underneath the orbit and out into the zygomatic bone here. So this CT was very powerful and very helpful for following this along and how this horse was doing. And this horse is doing well, but it's taken months to get back to this point. Also, you can check on how flaps are healing. So this horse had a maxillary flap as well here, which does look all quiet and nice compared to what's going on here. So this is a really cool feature. And I'm using Horos and Mac to do this myself, but the radiologist can also do this on their software that comes with the individual CT units. So is there any questions at this point, Sabrina, on this type of features of the CT and how we're going to use it to look at all these cases?
I have no questions as of now, so everything is quite clear to our attendees.
Okay. So now we're going to get into what the actual dental disease that we can evaluate with CT. And the two big topics that we're going to cover today is endodontic disease and periodontal disease. Endodontic disease has to do with all of the structures that are inside the tooth. So when we think about those, that would be your root canal, your common pulp chamber, your pulp horns, the infundibula, and also the live pulp. So of course with CT, we're looking at the hard dental substances, and we're not really seeing the soft tissue component of the live pulp. But one of the things that we can evaluate here is that teeth, as they age, the chambers in them all become narrower because of the deposition of dentin that's laid down and produced by the live pulp. So when we're looking at a right versus a left tooth, say a 109 versus a 209, and the 109 would have chambers that were bigger than the 209, we would start to suspect that that tooth is non-vital, or the pulp in it is dead because dentin could not be laid down. And so the chamber would halt its size where it was when it died, and the tooth that's alive will continue to narrow its chambers. So we use the term failure to narrow the pulp chambers or horns, and that's a significant thing that we look at in these teeth, because if this process has been going on quite some time, then we may have food impaction into those, we may have very large chambers, and it's an indication that that tooth has been non-vital or is dead. So the next thing then that we often evaluate is what people have termed the blunting of the apex or blunting of the roots. And that really comes from an inflammatory process called inflammatory root resorption, where the inflammatory process is eating away at the end of the tooth. And along with that then is the third one in the line there is periapical lucency formation, because if there's an inflammatory process causing blunting of the apex of the tooth, it's probably causing changes to the bone as well. So we get this formation of a lucency pattern over the top of this tooth where the bone is lifting away from the tooth. And often in that space, there's going to be granulation tissue or some type of granuloma formation, or the abscess and pocketing of purulent material there. And then anything that has to do with the structure of that crown fits an endodontic disease. That would be our crown fractures, root fractures, and even reserved crown fractures. So if we have a piece of tooth missing, so often we title that crown integrity. So anything that shows a lack of crown or integrity will fit in endodontic disease as well. So in this case, because I think clinical cases always are more fun to look at than just listen to the speaker yammer on about what all these changes are, is that this is the normal side of this horse. On this side, we see that we've got a lovely sinus filled with cottage cheese probably, and maybe even some food material with gas pattern in it here in the rostromaxillary sinus. And then lo and behold, we have a lot of bone lifting and a periapical lucency formation here through kind of the furcation area. And the furcation area is kind of that plateau in between all of the roots. So that's a nice formation of a periapical lucency here. And then we can also see that this tooth compared to this tooth has got a significantly larger common pulp chamber and wider pulp horn here, and also a periapical lucency formation. So in this horse, unfortunately, we had two teeth that were endodontically compromised. So moving on to, that was the sagittal views. And now if we look at the cross-sectional or the transverse view of this horse, same horse, we can see that change in the common pulp chamber, the root blunting here, and the periapical lucency that's happening over that too. So it's nice with CT because I can get several different views of this tooth to confirm that I'm going to have to come up with a treatment plan for a specific tooth. And then in the dorsal, where we can actually look straight down through the endodontic chambers, depending on how we've set this image up in the multiplanar reconstructs, is that we can see that there's larger chambers in this tooth here compared to the other side, and then the sclerotic bone that's surrounding this 11 as well, and in between or in the interproximal space of this 10 and 11 tooth. So this makes a pretty sound case that we've got problems with these teeth when we can visualize all of these changes in 3 different dimensions. So this is going to show us another case. I'll just pause this for a second. So this horse was presented as a middle-aged quarter horse, and it had a nasal discharge. So the idea was that this horse was coming in to have a sinus evaluated and potentially a sinusitis. When we performed the oral exam on this horse, we saw that the teeth in the 7 position here were kind of dysplastic. So you can see how the pulp horns are kind of crammed over towards the buccal side of this tooth, and then there was a production of cementum on the palatal sides of this teeth. Also, it had a missing incisor that we can see here. So kind of giving you a background on this horse's clinical exam. And so when we did performed a CT on this horse, and it was kind of interesting what we found and we confirmed with radiographs as well. But I want you to watch in this region right here. So we're going right down to the bottom of the occlusal surface, and now we're going to work our way up into the nasal passages. So we're going to see the apex of the 7s kind of leave here. And then as we go a little farther, we start to see an alien show up here, or some type of dental material density in the nasal passage of this horse. So what was really going on with this patient was there was a separate center of dental material, and you can see how the roots are ending here of the 6 and the 7. And the other thing I want you to, we just jump forward here with this a little bit, is I want you to notice the infundibula of these teeth as well, how big and gas-filled they are. Remember, 11% of horses will really, or 11% of the infundibula will be normal. So we're going to find a lot of gas and openings in infundibula. And the trick is figuring out, is the apex in trouble? Is that breaching through to a pulp horn? And so forth. So CT is really, in my opinion, probably the only good way to evaluate whether an infundibular caries is causing your problem. But the big issue with this horse is that the dental material that was in his nasal passage was growing bioslime, and that was creating the nasal discharge. We offered surgery to this client to remove this. The horse was performing well. Once they figured out that it wasn't a sinus infection in this horse, they're still considering this, but at this point have not opted for surgery. So just some stills of this showing the large infundibular caries in this dysplastic teeth here. And what I also want you to see is, look, there's a little tiny sinus cyst actually sitting in the rostromaxillary sinus here as well. So to just review, this is our sagittal of this horse, and we can see that cap of that material that we presume to be dental material. Without a histopathology exam on this material, we can't say for sure, but it sure looks like the density of teeth, both on CT and radiograph. And then we've got dysplastic teeth here, and then the dental material here. So the idea is that this horse probably somewhere in development had something happen where we got some of the germinal cells developing teeth that got pinched off in the nasal passage, and we formed this kind of odontoma looking structure in the nasal passage. So that's kind of just a short down and dirty of endodontic disease and some of the things that we can see. And now we're going to talk about periodontal disease. And periodontal disease, just to review, is all of the things that have to do with the tooth's attachment in the alveolar bone. So our periodontal structures are the cementum of the tooth, the periodontal ligament, the alveolar bone, and the gingiva, which, of course, the gingiva is not something that we're going to be really examining with CT. We're going to be using our clinical exam with a mirror or an oral scope to look at that. But the other structures we can start to take a look at pretty close. And in the periodontal ligament, we're going to be looking at the width of that. So an increase in the periodontal ligament width can be related to periodontal disease. Horizontal bone loss between, so that's the bone in this formation. So if we see the bone dropping away or quite a bit away from a tooth in a horizontal fashion, that's horizontal bone loss. Our deep pocketing that we have between teeth is often a vertical bone loss, or we can have combinations of that. And then if we have a very deep periodontal infection that travels down alongside a tooth and actually infects around the apex of a tooth, that's a perioendo lesion. And then the hallmark on your clinical exam for periodontal disease is usually a diastema, which we can see that this horse has one here. And then we had food impaction here. So this 8 was our concern. And what had actually happened in this case is that we had food travel down and we caused a huge periodontal infection with an endodontic infection of this 9 tooth and then a big draining tract out the bottom. So this was all on the medial side of this horse's jaw. The lateral side of this horse's jaw was entirely normal. And this just was a very, it had been going on for several months and was so advanced that when we actually cultured the bone from this region and some of these sequestra, we grew an actinomyces bacteria. So it was, this horse lived on doxycycline for months until we got this cleared up, but we ended up extracting the 8 and the 9 tooth based on all of our views here. But I think CT, we forget to use it sometimes, or we don't consider using it in periodontal disease. And I'd like to see that change because I've been fascinated how much more problems we can see with CT in these periodontal cases and how deep these pockets really go than I can even say on an intraoral radiograph. So even with an intraoral radiograph, we can get high definition of this area, but this this really brings to light the extent of the damage that's happening. So then I made a few 3D reconstructs here and kind of bone windows and soft tissue windows that actually shows how advanced this was on the medial side of this mandible. So we had this at 8 all the way back along this horse's, back to the 10 tooth, and then down between 8 and 9, and then was coming out through the mandible. And you can see here the changes, but the lateral side of this horse's mandible was entirely normal. So going to another periodontal case, this was an older warm blood mare that came in with a sinusitis. And to show you, we had a large diastema between the 10 and the 11 tooth here, and we can see that there's just no bone there at all. And you can actually see the tract going up between 10 and 11 here. And then we also had an endodontically compromised 9 with the crown missing off of this tooth. And this was kind of the thought was the problem was they knew that this tooth was fractured, but the actual sinusitis was secondary to this diastema between these two teeth. So this horse was literally pumping food up into her sinus and it was coming out her nasal passage. On the dorsal view, we can see this large hole here that was made by the periodontal disease through the interproximal space of those two teeth. Everybody always wants to know, what did we do for her? Well, we elected to extract the 10 at this point, and we left the 11 thinking that someday we would have to, and then we built her a bridge of human crown and bridge material called ProTemp between the 8 over that 9 into the 11 to basically build her a prosthetic tooth. And because this horse needed to be, she didn't do well on pellets, she wanted hay badly, so we did that and put her back on hay, and within 3 months this had closed, to my surprise. And when we removed the bridge to check, there was actually tissue healed. We re-scoped her sinus, everything was clean. We reinstalled another bridge across here, and she's been pretty symptomatic or asymptomatic since then, and that's been a year. So we've talked about periodontal disease, we talked about endodontic disease. Yeah, got some questions?
I do have a question for you. So now that you have the CT available, your treatment of these diseases, have they drastically changed?
I would say that the information that we've gotten is a lot more. So if we would have gone back to this case here in times before CT, I probably would have gone for extraction of all 3 of those teeth, because I wouldn't have been convinced that the 9 wasn't causing me some type of problem. And I would have been convinced from the radiographs that I should have extracted the 11 as well, which would have left me with a huge hole to try to heal up. So sometimes CT has actually made me more conservative in what I do surgically in these horses' mouth and potentially extract a specific tooth rather than just taking out 2 teeth in the case of this one where there was periodontal disease in between them. So yes, it has changed drastically what I'm doing. Plus it gives us a little more confidence of what we're actually performing in surgery is going to be going after the inciting cause of the disease process.
Okay. I have another one.
Sure.
How do you differentiate between a septic fistula and the mandibular fracture on CT compared to what, the one that you saw before, CODA?
So on this case.
Yes.
Yeah, so this was interesting. So ask the question again. You cut out for a second, Sabrina.
How do you differentiate that this is a fistula that's septic or not a mandibular fracture?
Yeah, this because it was on the medial side of the mandible, this could have started out with trauma, of course, but this horse had reportedly had periodontal disease for a long time that had left untreated from previous oral exams on this horse. So we assumed that this probably came from a deep periodontal infection more than what it came from a fracture or trauma. Now, when I first looked at this horse, I thought it was going to be just a straightforward fracture, but like I said, the lateral rail of this mandible was entirely normal. And we've had another case that we'll show that was from trauma and started out as fracture and then developed the space between the teeth. The other thing to remember about this horse, it was also a very cushionied horse as well. So it's a very good question, and I'm not sure that we can say for 100% that this is definitely not from trauma, but since we had a long-standing history of food impaction between the 7, the 8, and the 8 and the 9, and then developed this, we went more with the primary periodontal reason.
I have one more, and then the rest we'll save for later. If you extract in the last case that you showed, if you would have extracted all these 3 molars, or at least 2 of them, how would you manage such a large defect to avoid an oral nasal sinus fistula?
Well, so to start with, the CT proved that we had a fistula already. Okay, so there you already have a hole, and these would be very problematic because when there's nothing in front of or behind where you're going to try to make a packing, it's difficult to keep it in there. And we'll talk about fistulas a little bit more in some of the slides in the later part of the talk, but we would need to build some type of pack and probably bring stainless steel wire or something out and place buttons on the forehead to hold it into place. So those become more problematic. It worked out well that we could leave this 11 and build a prosthetic between these teeth here so that we could hold it in place without having something still exiting the face on this horse.
Okay, the rest as we go, I will save them.
All right, we'll move along. So I want to just talk about what we can see in these transverse images, sagittals and dorsals when it comes to nasal discharge. And so we're going to go through some of the anatomy first because I think that's important to understand what you're looking at. So to start out in the nasal passage, we have 2 structures that recently been identified by Dixon's team about 4 or 5 years ago called the conchal bulla. And so we have a ventral conchal bulla here and dorsal conchal bulla here. The ventral conchal bulla starts at about 2.7 and the dorsal similar region, and they run back and run up against basically the sinus compartments. So when we're looking at a nasal discharge, I want to know, is it unilateral or bilateral? We want to evaluate the nasal passages, the bullas, the paranasal sinuses, and the guttural pouches. So we're going to talk about all of those a little bit, and I'll definitely say that I'm not an expert in guttural pouches other than the fact that every nasal discharge that comes to me gets scoped to look in the guttural pouches. So if we play this little video, we're gonna basically move back through the nasal passage of the horse to see how these run. And if you follow this, you're gonna see the sinus come into view here, and the dorsal one is gonna keep going. So here's our sinus, and then our dorsal kept going. Just pause this and we can run back there quick and show you kind of where that all starts to come into play. So right here, we start to lose the ventral conchal bulla. We can start to see the sinus infraorbital canal. So it's starting to end here, and then we're going to start to see sinus, and the dorsal is continuing here as it actually runs back a little bit farther than the ventral one, if the horse has read the anatomy book. So now we're fully into ventral conchal sinus here and rostromaxillary sinus here, and then here's our dorsal still here. And as we go back a little bit farther, then you can see the dorsal end, And then we can see the maxillary septal bulla come into play. And that's this structure here that's dividing rostromaxillary, ventral conchal from caudal maxillary and frontal and sphenopalatine. So this is our actual drainage angle coming out into the nose, but you can see that the bullas are gone in this region. So when we're talking about these structures, they can be a real pain in your backside because you can have a sinus that you get totally cleaned up and there's no more infection in there and the horse still has a nasal discharge. And if that's your case, CT is a wonderful option if you don't already have it, because once these things are full of material, they're very difficult to access and to get to drain and have them resolve. So this is the normal side here. We can see the ventral conchal bullous, dorsal conchal. On this side, we have two normal ones here, and both of the ventral and the dorsal are full of material. This is a sagittal view of that, and what I want you to kind of recognize is that there's little septae that actually run in these things. So they're not just one big blind pouch here, they're actually walled off in themselves as well. So that's what makes them kind of difficult sometimes to get cleaned out, is that they can fill these and they don't, you can get into them sometimes from a frontal flap here and access them to clean them out, create a drainage port, but you've got to almost break down every one of these little septae to get in there and clean that out if it hasn't already been done. The nice ones are the ones where they're actually blowing out a big hole into the nose and you can access them with a scope and you can flush them or even instill a catheter up the nose to try to flush them. But I just wanted to show people a nice case of a horse that had the sinusitis kind of on the run, but we had big, huge fillings in both of these conchal sinus, or their bullas. So just a review of the anatomy here. On the lateral side of the infraorbital canal, near the 9 tooth, we'll have the rostromaxillary sinus or rostral to the septal bulla. We have the infraorbital canal here, ventral conchal sinus here, frontal sinus here, and then this is our maxillary septal bulla and our drainage angle out into the nose. So this is a flap. Cleet Griffin and I were at Texas A&M. We're discussing a case this week, and he sent me this picture, and I asked him if we could use it because it's really neat. But so this is a left-sided frontal flap, and you can see that the infraorbital canal is here, septal bulla is here, and it's been removed. Behind that then is our caudal maxillary sinus down through the ostia here. Our rostromaxillary sinus is sitting here. The ventral conchal sinus is this little slit that's sitting on the medial side of the infraorbital canal, because this is all one continuous structure here as the infraorbital canal. And then what was the problem in this horse was the dorsal conchal bulla right here, as you can see protruding up into the sinus compartment. So this is all frontal, or surrounding us here. So this is the bulla, and it was all full of inspissated material, and they made their access into this to debride and clean that out through a frontal approach. So when we're looking at these cases and what sinuses are involved in this transverse section, we can see that we have rostromaxillary sinus here, ventral conchal here, and the septal bulla is being pushed actually a little bit dorsally here. So this is all filling within the rostromaxillary sinus and spilling over into the ventral conchal, compared to our normal patient here where this is all nice and air-filled. But CT with these multiplanar reconstructs really helps us plan when we do surgery what we're going to get into. Is it pushing on the ethmoids? Is it distorting the head? Is the infraorbital canal complete, or is that going to be have basically an exposed bundle of nerves running through all of this mess when we go in to perform surgery? So this is that case again of the periodontal disease, and we can see that this actual kind of fuzzy material that doesn't have a nice boundary on it that's protruding out of the septal bulla here in the rostromaxillary, this was all food. So this horse had destruction of her septal bulla, and this was all one big compartment when we went in surgically, and we could tell that from the CT, and the food, due to gravity, had been squeezed up through here and then pushed forward and down here. And then this, as we can see, is a nice horizontal line that's all fluid laying in the floor of that caudal maxillary sinus. This was the normal side of that horse, so we can see the infraorbital canal here on the sagittal view. This line is representing her septal bulla. frontal sinus, caudal maxillary is back here, rostral maxillary is here, and then the ventral conchal is going to be on this side of the infraorbital canal. So not only can we just look at the sinus compartments, but we can also look at the guttural pouches as well. The throat, epiglottis is here, temporal hyoid bones. And this was a case of, you can see that this horse has very advanced temporomandibular joint pathology, and she was quitting. So the question was, is what all is going on with her hyoid bones and also her guttural pouches because of the extent of this disease process. So we were interested in looking at her guttural pouches. So we'll play this video as well for you. And this is the dorsal. I want you to appreciate, this is her hyoid bones here, how they're not uniform in all of this different, all of this degenerative pathology that's happening with the temporomandibular joint is being very proliferative and pushing into the guttural pouch and actually changing the position of the hyoid. So we were actually concerned that this horse was having some mastication troubles just from the pressure on the hyoid and the change in the position of it as well, from tongue function, because she really did not eat hay well at all. She would eat a soupy pelleted diet, but when we further looked at, we were CTing her to actually see the extent of the temporomandibular joint pathology, but we also found that she had problems with her hyoid as well. And this is just a transverse of that horse to show you what we could actually see from that. And you can see the nice compression that's happening down into her guttural pouch from all of this pathology. And we'll show more images of her later. Do you want to stop for some questions quick, Sabrina?
I do. When you have in the nasal passage, if you get infected material like soft tissue or necrotic bone, how do you handle this? Do you pick it away with the endoscopy like for a long time, or do you go more aggressive and do surgery externally and approach it?
Most of the time we're trying to do it with the endoscope. I'm not a huge fan of making large flaps through the nasal bones if I don't have to. It's very bloody surgery. So generally, we're pretty conservative with how we treat that. We're first dealing with the sinus. If we have the conchal bulla involved, we'll clean them out as well. But then we use long instrumentation, the scope generally, and using sprays and things such as the phenylephrine sprays, or now there's these long syringes that we can inject lidocaine with epinephrine in them to help control bleeding as well.
And remember that case that you discussed early when you removed the 10 and you had to make a bridge between the 9 and the 11? What kind of, can you repeat again the prosthetic material that you use?
It's a Garant Pro Temp. And it's a human crown and bridge. It's basically a bisacrylic type material. We'll show another case of that here in just a minute too, where we use that as well. But we have a research project going on with that where we're going to probably present a paper on about 18 cases in the next year on that material.
Okay, that was it for now.
Okay. So we'll talk about some of the fracture things that we can see. So I've got a couple cases here with just some fractures that we had happen where this was an older horse that sustained trauma. It was noted to have happened in the pasture. In this horse, radiographically, we could see some small lines running through here, but we ended up wanting to know, the client was very proactive. She was getting a big callus radiographically as well in palpation. So we sent her up for a CT, and we followed her with two CTs because she had formed a draining tract. So we're really interested in which tooth was involved and what we were going to do about this. But the interesting thing on the CT again was this horse I know looks a lot like that other horse, and the other horse, Coda, that we showed before, not disputing that could have started with trauma as well. But this horse really didn't have periodontal disease to speak of in her history, and we had performed the dentistry on her for years. So this one, we had an inciting cause here. If you would say that the owner had noted she'd come in painful from the pasture, but this was also cultured out to be. We had a very aggressive bacteria. I can't remember which one. It wasn't an actino on this horse, but it was only sensitive to chloramphenicol. So we put this horse on chloramphenicol. once we saw that this was bridged with a nice callus, we extracted the tooth that was in the draining tract primarily, and the draining tract healed up within 5 days after that. So, but what was very interesting is you would look at this case radiographically and see these sequestra and all of the small pieces and think that we were going to have to intervene and go in and debride all this out and clean it up. And this horse, honestly, we followed this with CT, and I never took any of these pieces out. And this horse healed up entirely. So it's kind of amazing to me that this was a case where CT kind of helped me pump the brakes and not go into an older horse and open up the entire jaw and remove tons of sequestra and debride a lot of things. Because once she was on an appropriate antibiotic, everything started to settle down, and she really healed very well without any major surgical intervention. And I was very surprised about that. And in that first horse that we showed kind of taught me that, because once that horse was on doxycycline and appropriate antibiotics due to culture, things really settled down after the teeth were extracted and we could get things to heal up. So this was a case of it's a younger horse that came in, I believe, that had a enlargement over the side of its face that was presumed to be a tooth root infection that had sprung up over the course of a few weeks. And the horse was very painful, kind of on the leading edge of the facial crest. And when I did the oral exam on this horse, the tooth looked entirely normal. Radiographically, the teeth looked decent, but we were still just trying to figure out on a dorsal ventral projection, I thought I could see something that looked enlarged along the facial crest. And so I was presuming that there was some type of facial fracture there. So we performed a CT on this horse, and I want you to watch very carefully what happens along this facial crest. So when we stop right here, we can see that there's a sequestra laying right there. And then as we follow this horse up farther, you can see these lines running here, and enlargement along the maxillary bone as we head up towards the frontal region, and we can still follow a discrepancy in this region. And actually you can see it again here. And as we go even farther, we're still seeing it all the way up to we're actually coming back forward then and right across into the kind of toward the central midline of the horse's head here. So I built you a 3D here so that you could see what's going on, and notice this fracture line here. And it kind of meanders down here and then comes forward down to the facial crest. So as we now stop this again, and you gotta kind of play with these images and get familiar with what you're looking at, and play with the window leveling when you're making 3Ds, because this right here is where the horse moved during the CT. So that's kind of an artifact. So it's a very straight line across the horse's head. And you gotta have to kind of notice those and figure out when you're going through your slices to make sure that you're not calling motion artifact a fracture. But this one we can see only starts at midline and comes along the side, where it's not on this side. And if it was an artifact, it would be going all the way around the horse's head. So to just finish this out then, as we rotate and position this horse, we can see that nice sequestra laying right here. Also to note, young horses, we have to remember that the bone over these tooth roots or apex of these teeth is very thin. So it's no wonder that they get in scuffles and skirmishes and cause trouble with their teeth, because there's basically very little protection for them when they're young. So this was an interesting case. We knew that there was some swelling in this region. It was proposed to be a tooth problem, but it really wasn't. It was a fracture. And when we questioned the owner, she had this horse in with somebody that it was kind of fighting with, and they were misbehaving together. And we kind of could go back to a time where she realized that there was trauma. She just didn't realize that it was this extensive. So we'll go on and talk about temporomandibular joints a little bit, because that's a little bit of an area of interest for me. And part of it is due to this horse here. It's a friend of mine's horse that they bought, and the horse had had a history of having a laceration in this area 4 months prior. It was healed up. The horse seemed to be doing all right, but after they bought it, the horse continued to masticate poorly, quid hay, lose weight. So they brought it in for a dental exam, and its teeth were pristine. They were very nice. And so we started with just imaging the temporomandibular joints with plain radiography, and then I tapped this temporomandibular joint because I could tell that there was some increased swelling over it, and cultured it, and we grew a strep zoo from that temporomandibular joint. So this was the films of this horse, and we can see the normal left temporomandibular joint here in a 70-degree tangential view, and on the opposite side we can see that there is a problem with this temporomandibular joint. We've got erosion, we got osteophyte production, but realistically, until we CT'd the horse and looked, we wouldn't have realized that all of this was going on. So here's the abnormal joint on a 3D reconstruction, and you can see all the erosion happening. And this is the horse's normal joint on the opposite side here in a 3D reconstruct. So what we did for this horse is we did a mandibular head osteotomy and removed the meniscus as well, and then curetted and cleaned up the petrous temporal bone here. So we actually excised this head off. And once that was done, this horse went back to eating hay normally within 24 hours. It amazed me how well this horse had done. And I'd been involved in some other mandibular head osteotomies, and they had done very well, but this horse literally would quit everything he was putting in his mouth was due to forage. And we had a problem because the horse ate so much hay the first night after surgery that he tried to get an impaction. So none of us realized how well this horse was going to eat post-surgery, but he now is doing great. He's 2 years out. He's in full performance work and is in normal body weight. So kind of a really fun, nice story of a horse that had what could have been a very life-ending problem that has done very, very well. This is another one that I don't think would respond to mandibular head osteotomy. This is the horse we showed before with compression in the guttural pouches. You can see that we have barely any type of joint space here. We have some joint space over here, but until we actually, and this is a dorsal to ventral projection and seeing all the proliferation that's happening here. But in these views, I wasn't as appreciative as the amount of disease process that was going on until we performed the CT. We can see here that this is all a lot of production on top of where the normal joint space should have been, and it's all moved up here with thinning of the petrous temporal bone. Here we have thickening of the petrous temporal bone, a lot of proliferation to the mandibular head. And this horse just, we opted to not do surgery on this because they honestly didn't have the money for anything either, but this horse is doing okay on the soft pellet and mushy diet, but this was a very, very advanced case of temporomandibular joint pathology. Talk briefly about dentigerous cysts and the importance of CT here. The last two cases we've had of these have ended up being euthanized due to there being teeth that actually were communicating with the brain vault. So we can look at this cross-sectional video here. And for one thing, on radiographs, we were convinced there was kind of one big tooth, and what there actually was here is two teeth laying horizontal. And when we scroll back through this, you can see that we lose the bone in the calvarium here, and it's actually into the brain vault. And if we move forward, you can actually see that the petrous temporal bone is very thinned by this and how closely that is coming to communicating with the temporomandibular joint. What was interesting about this case, it was highly productive. There's a lot of fluid coming out the little fistula by the ear. You could milk that out, and 20 minutes later, you could milk another 20 to 30 mils out of it. So we were either we should have tested the fluid, but we did not. We were either getting CSF fluid coming out through there or joint fluid of some sort, because it was extremely productive dentigerous cyst. So we talked to the client about the risks of going in and removing this, potential for seizuring and issues with the brain, and also having the temporomandibular joint in so close of approximation with this, and the client opted for euthanasia. It's another one that was in just recently. And if we stop this, we knew we had a big dental mass here, but it's actually a culmination of several teeth in this horse. You can see that it's already close to the brainstem here. We move forward into the actual brain. We can see that there's tooth material in the calvarium and in the brain. We opted to not do surgery on this horse as well. The client consulted several other neurologists and surgeons around the country, and they all said that it wouldn't have been a good prognosis. In about 3 weeks after the CT, the horse started having horrible neurologic signs and went down and ended up being euthanized. But this is just showing you how important CT is in these cases, because it really can guide you as to what you're getting into, especially in this region right here. I'm going to move on to oral nasal fistulas kind of quickly, because I think that CT is a must in these cases to look for small pieces of material that can be left behind. So we'll move through these slices here, and we can see that there is a piece of material laying here. They had to have a patch or kind of a rubber plug over this horse. We have some gas in this fistula as well. And then we have a small piece of dental material still left up here. So CT is really sensitive for these small little pieces of dental material that can be left behind, and really help and guide you into what you need to do. In this case, that was all debrided and cleaned out well. And then we ended up using one of those pro-temp bridges on this horse again to help it to seal up. This is about a 9-year-old jumper that had a 10 extracted, and then subsequently it was a clean oral extraction, but subsequently then developed a very large oral sinus fistula. Radiographs are shown here in the dorsal to ventral oblique and our dorsal to ventral here. And really where you can kind of see the fistula was this region right here on a ventral to dorsal, looking at the palatal view of these cheek teeth. So we knew we had a problem clinically because we could see that there was a fistula. You could flush into it and have her come out of her nose. This horse was hauled from the West Coast out to us. And when we performed the CT on her, it's when we could really see the extent of this. And we had a big tract running up into her sinus. This is a polyvinyl siloxane plug that's in there. And what I find with these in these cases is that the plug does keep the majority of the food out, but it also acts like a pump. So when they're chewing on that, they're actually just pumping things around it and pumping food up through it. And I think that's why when we put these solid, hard bridges in these horses and bond them to the teeth, that we actually help to stabilize things here, and it doesn't act like a pump. And then it also puts pressure on the bone, so they're chewing on it. And because it's amazing how fast this bone will fill in. So we can see the fistula here on the dorsal view, but we put a fistula in this horse. 2 days later, we put her back on full hay and feed. And then we continued to flush her sinus to treat the sinusitis for 2.5 more weeks. Then we pulled the tube, we scoped her sinus again. She was clean. We left the bridge that we placed in here for 2 months, and then we cut the bridge out, re-CT'd her, and at that point this bone was filled in and she no more had a tract from her mouth to her sinus. And then we reinstalled the bridge just to be safe and sent her home. So she's now back. That was done in December, so she's now back home in the West Coast, back in full work, and she'll probably wear that bridge for the better part of the next year to 18 months. The longest I've had a horse wear one was 18 months. So just to kind of bring this all together in a conclusion, I think CT is highly useful, and it's really helped us make a very accurate diagnosis, even though some cases you're still scratching your head at the end of it, and those are still frustrating, and that mostly is because of the chronic nature of a lot of these cases. You'll have a sinusitis that's been going on for several months, and you've got swelling and changes over several teeth, but really helping you decide which is the tooth that's the most affected based on CT. And don't forget to take some plain films and compare them with your CT, because you can get some summation with the films that you don't with CT. But on the other hand, you can go back to those MPR images and you can stack up several slices together as well and look at more information. So that might be kind of confusing, but just think about a lot of what we're looking at here today is just individual slices, where you can ask the computer to build you those into 3 and 4 slices together, and you can look at a bigger area all at once. So this presentation was fun to put together, but I wished I could have even put more in it because I knew I was going to run out of time in an hour. So I'm sorry if I'm not answering every question or everything that can come up with this. But CT, in my mind, is 100% a necessity now in our dental practice. We didn't know how much we were missing it until we've had it now, and especially in these very, very chronic cases. So thank you. I hope this was worth your time coming this morning, and I appreciate the opportunity to talk to you guys.
Dr. Henry, there are a couple of questions. Most of these images were all equine and concentrated on equine. And as we all know, you're also boarded in small animal. Do you use CT as much in small animal as you do in your equine patients?
I don't have CT in my own practice. When I was at Davis, we heavily used CT in small animal. Right now, I have to farm out my CT cases. So I would say that if I had CT in my own practice, I would be using it as much in small animal as I do in horses. And that is coming in the future. But there's definitely as much of a reason to perform CTs on oral neoplasias, jaw fractures, TMJs in small animal. And a lot of what you're seeing, the information that I've been trained to look at and how to look at for the horse, has come from my small animal background.
Another question, have you pleasantly or unpleasantly been surprised now you have CT to your disposal?
Oh, pleasantly surprised. Yeah, it's almost now my safety blanket. Before I do sinus surgery or anything, I love having CT. And especially because now it's reasonably economical for the owner. We don't have to do general anesthesia. We're getting beautiful images in the standing horse. Those are all things that are really, really important. I mean, when I was had the opportunity to be in Europe for several different times in the past 15 years, and they've had standing CT much longer than we have here. And I actually helped put together the first standing CT in Texas that was in this country many years ago, and saw the need for it then. It's just that now with the Asto and the speed that it can do, the reduction in the kind of the technique that has to be used, in just the overall convenience of Asto, it has made it a lot easier. So that's where I can ask for a CT on a horse and I know 30 minutes later it's going to be done for me. There's not a lot of screwing around trying to get the horse compliant and get it positioned and everything else. So not trying to sound like a salesman for Asto, but I've just been very surprised on how easy it is to obtain these images and to get good images.
Is it possible to diagnose TMJ degeneration on X-ray or only by using the CT?
No, you can do a reasonable job looking at temporomandibular joints with the radiographs, but you're going to only pick up the advanced cases or cases that are more advanced. CT is definitely way more sensitive, and we've proven that in dogs that the only really good way to look at CT, dogs and cats, is to use CT. And we're finding that in the horse too. To find out the actual extent of the disease process and how severe it is, CT is the only way to go.
Do you think tomosynthesis is the intermediate step between X-rays and CT scan?
I'm not as familiar with that modality, but I think the hallmark is definitely CT.
Okay. And then I will answer the question about the sedation protocol. We have used so far we sedate our patients with a cocktail. We use an acepromazine IM before, about 30 minutes to 45 minutes before we start handling the horses to just get the edge out of them. And then we only use ditomidine just before IV to sedate the horses. We started out with a protocol including a butorphanol. But we did not, the horses moved too much. There was a little bit too much movement and swaying of the horses. So right now we pre-sedate them, we pre-medicate them with an acepromazine, depending on the size of the horse, anywhere from 10 to 15 milligrams IM. And then we use ditomidine IV, and that depends on the horse. It could be anywhere from 3 to 8 milligrams, depending on the size and how cooperative the horse is, to actually get the CT scan done. And that works pretty well, and they're pretty sedated to stand nice and still. And that's also for heads as well as for limb CT standing that we can do as well with this machine. Any other questions? Then I would like to thank Dr. Henry for sharing his expertise with us this morning. And I would like to thank everybody for attending our webinar and wish them all a very wonderful weekend.
Yes, thank you everyone for attending. It was, again, thanks for the opportunity to put this together and talk to you all.